Hi, this is Elliot Fishman, and welcome to Part 4 of our evaluation of renal masses. In the last several parts, we've discussed various renal tumors. We've looked at some of the specifics of renal cell carcinoma, clear cell, papillary cell. We've looked at transitional cell carcinoma. We've looked at lymphoma. And now we're going to look at several other things that you need to think about at times, and so we'll discuss them. One is chromophobe renal cell carcinoma. It's around 5% of renal cells. The majority of patients are male. It's about a patient in their 60s, a little bit lower than clear cell. 46% were incidental findings without clinical symptoms. Metastases are rare, and these tumors are not very aggressive because their 5-year survival is well over 90%. The lesions are typically hypovascular. We published an article about this way back when. Chromophobe renal cells are most likely to present as well-circumscribed, relatively homogeneous masses, often with a central scar and an enhancement pattern that is hypovascular relative to papillary variants. In some cases, it raises the possibility of this diagnosis prospectively, and this could be important clinically because nephron-sparing surgery would be very useful in these patients because of their low aggressiveness of these tumors. We also noted that the mean maximum diameter was about 5.2 centimeters, 46% of the tumors were homogeneous, 85% of the lesions were either completely solid or mostly solid, 14% showed calcifications, 34% showed a central scar. Now, central scars, of course, are challenging. A tumor necrosis can give a central scar, and we looked at clear cell, but it's usually a more defined scar. Mean maximum attenuation values were 88 on arterial, 84 on venous, and 60 on delayed. So it's not very vascular. It's more like papillary renal cell carcinoma. So it's not going to be confused with a clear cell by any means. Here's a good example. A very well-defined lesion on non-contrast CT could even theoretically be a high-density renal cyst. You give IV contrast, there's maybe a central scar, but the lesion does not enhance very well, but it's very well defined. You can see it very nicely again as we look at the coronal view. And then on delayed phase imaging, you see some of the cystic changes, but again, it's solid and homogeneous. Again, it's going to be a renal cell tumor. Okay, it's not going to be a high-density renal cyst, obviously. It could be a papillary renal cell carcinoma, but as you mentioned papillary, you also should say, hey, the mass is not very vascular. It's well-defined. Yes, it could be papillary, but it could be clear. It could be a chromophobe as well. The one thing we could say it's not is a clear cell. So this patient would undergo a partial nephrectomy, though it is challenging because it comes very near the hilum. Here it is on the 3D mapping. Almost looks like it has a pseudocapsule. A very nice example. Another case, same right kidney, but instead of anterior, this is posterior. It's also a bit smaller, but it's solid. You can see it measures about a mean of 28 versus the normal kidney of 26, so it's not much different than the kidney, well defined. And then when you give IV contrast, it goes from 26 to 72 Hounsfield units. Okay, so it's enhancing, but it's only 72. 72, you got to think of papillary. Average papillary is 62. You got to think about chromophobe. Again, here it is a little bit enhancement, but again, low-level enhancement, well-defined. You can imagine, but you need a great imagination for a central scar. So again, chromophobe and papillary overlap. I mentioned about 14% of calcifications. Here's a more aggressive-looking mass with calcification. I'm going to be thinking on the non-contrast. This is a clear cell. Here it is, a few more images. It looks aggressive and worrisome. But again, when you give contrast, it's not enhancing a whole lot, so it's not going to be a clear cell. Papillary occasionally has calcification, though that's rare. Chromophobe is more common. Here's the lesion kind of centrally positioned, so it's going to be a very tough call if you even considered a partial. But now a hypovascular mass with coarse calcification, Yes, you do need to think about papillary, but you got to think about a chromophobe renal cell carcinoma. Here it is as we go from the arterial to excretory phase imaging using volume rendering, showing you those calcifications very nicely shown, distortion of the renal pelvis and calyces. Because of the central nature of this tumor, there's no way you can do a partial nephrectomy, and this patient had a right nephrectomy. Now, the last thing I'll mention is metastasis. Metastases to the kidney are not that uncommon, and we often don't think about them. Survival appears to be longer in patients who are candidates for and are treated with surgery. So again, it's an important diagnosis to be able to consider, but again, lymphoma, think about extra renal disease, but you don't really think about global tumors. I've seen pancreas go to kidney, that's rare. Lung cancer is more common. So the most common tumors in descending order were lung cancer, colorectal cancer, head and neck tumors, breast, soft tissue, and thyroid. And again, this is consistent with historical reports noting that lung are the most prevalent source of metastasis, and again, the other ones really follow. Over half the patients in our cohort were asymptomatic. So Mets to the kidney is uncommon, but you really need to think of it, especially when you have a patient with a lung cancer. Here's a patient with breast cancer. You can see a mass in the left breast, pleural effusion, adenopathy, lesions in the spleen, implants on the pleura, and then there's a mass in the patient's left kidney and in the right kidney. If you didn't know about the breast lesion, I would look at this and say this looks like lymphoma. Bilateral mass is not very vascular, unlikely to be renal cell, though we do have bilateral renal cell, can occur with papillary. But again, lymphoma will be at the top of my list. But because we know the patient has breast cancer, you got to think about metastasis, and this was metastatic breast cancer. You see mets in the liver, mets in the lung, bilateral masses in the kidneys, metastatic disease to the kidneys from breast cancer. There's also bone involvement. A really impressive example. And again, it makes us think about if you have a primary tumor already known and you see renal lesions, surely if they're bilateral, which is less frequent, you got to think about metastasis. But even when unilateral, you got to think about metastasis. This was a patient with hematuria and non-small cell lung cancer. We were restaging this patient. You look at the kidneys, they look a little bit full. And then particularly the lower pole is calcification in the left kidney seen. But then when you give contrast, bilateral masses are again seen. Looks again similar to the prior case. Again, if this was the only images, I'd be thinking about lymphoma. But metastases are a good thing to think about. And this was non-small cell lung cancer. Patient also has bone lesions. Again, that same principle. You have to think about other sites of disease, and then you think about metastasis to the patient's kidneys. Again, mets to the kidneys are typically hypovascular. You can have contralateral mets from a renal cell carcinoma like a clear cell, but here, bilateral hypovascular lesions, think lymphoma, think metastatic disease. Just a very, very nice example. Can you get bilateral transitional cells? The answer, of course, is yes, but this looks like solid masses and not TCC. So I've gone through a number of different things. We've gone through the principles of injecting contrast, arterial phase, corticomedullary phase, excretory phase. We've looked at the various appearances of lesions. We looked at some of the tricks and some of the challenges distinguishing the lesions. We looked at things that are great mimickers like lymphoma or even metastatic disease. We looked at some of the pitfalls, particularly in not recognizing transitional cell carcinoma and not recognizing smaller tumors. Lesion detection for renal masses is only step one. The importance of thinking about the primary tumor, helping the urologist out. Again, think about things like chromophobe renal cell carcinomas, particularly for hypovascular masses. The lesions have specific signatures, though they're not always going to be perfect. You need to think about it, and if I think you think about it, I think you're going to do a great job. We're always learning and we're always being challenged by the kidneys. overlap of renal masses to inflammatory disease to infectious disease, involvement of peri and pararenal space ranging from lymphoma to melanoma to things like Ernheim-Chester disease. There's a lot to think about, there's a lot to learn, and hopefully these lectures did help you. And with that, I wish you a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.